Hi, thanks everyone for giving me a chance to talk tonight. Thanks for coming out on your weeknight. Let me just figure out how this works here. I need a hand here. So I had to be the odd one out. I didn't use PowerPoint. I used a different program, so it's causing problems already. I apologize for that in advance. All good? All right. Okay, that looks more like it. So I'm going to be talking about really expanding the opportunity for the treatment of lung cancer patients. I'm just going to start here by talking about how we used to do things. So how do we used to discover treatments, or how do we used to pick what was at the time the most cutting-edge therapy for somebody with lung cancer? And it used to be a very linear approach. So it started with, someone has an idea. Let me get this laser pointer out here. Someone has an idea. You sit down at your bench side, you do your basic science research. Everything works out well, because it's every time it's as easy as that. And you start a clinical trial. So you start enrolling patients with lung cancer, and you say, hey, I have this great idea for a therapy. You move on from phase 1 to phase 2 to phase 3, and eventually it gets regulatory approval, and you start treating your patients with this therapy. So what's the problem with that? There's a few problems with that. First, it takes decades. Okay, some of the treatments that we use for lung cancer patients were developed in the 80s. I was born in the 80s, so I don't have enough patients to wait another 30 years before I get to try something new for the benefit of our patients. So these are highly iterative, they're multi-year clinical trials. One generation of patients essentially informs our treatment decisions for the next. So the treatments we use are often 20, 30 years old. And I think that's in part responsible for the very slow increase in survival that we've seen from decade to decade. Another problem with this model is there's a heavy focus on patients seeking a last resort. These aren't necessarily the bulk of the patients that we see anymore. And not only that, it might be too late to offer these patients a benefit. This isn't the bulk of the patients we want to treat. We want to get to them earlier when we can really make a difference. And the bench to bedside translation, like I said, is highly linear. I'm having a lot of trouble today with these slides. Here we go. Okay, so can we flip the model on its head? So here's just sort of a graphic to show you how we do things now. Here you have a bunch of patients. Here they are. They all have lung cancer. They get enrolled in the clinical trial. And then we wait a bunch of years, 5. That's when we consider things to be a cure. And we look at the survivors. And we go back in time, looking at these survivors and doing correlative studies. So what can we see in these people that did well, that we can translate back to that initial cohort and then start moving forward? So you have mutation X, which you'll get more talking about later. You seem to do well with drug Y, so now we can start doing that. But wouldn't it be better if we could look at all those patients at the beginning and maybe predict how they would do before we wait for their cancer to come back or for them to die of their cancer? I certainly would prefer that approach. So here's Mrs. Smith. She has lung cancer. Why can't we study that lung cancer? And the answer is we can. So what I'm showing here, and you'll get a little bit more information about this as the night goes on, is we can take that lung cancer and we can put it in a mouse, or we can put it in a petri dish, and we can do all of the studies that we would do on patients at a given point in time, but that traditionally took 20, 30, 40 years to get a beneficial clinical outcome, we can do in real time. And so this mouse can serve as sort of a patient avatar, where we can test all of these drugs that we want to test without the cost or the risk to people, and kind of get an idea of how these patients might respond to therapy. So we can profile, we can predict, we can try the best available therapeutics today, and obviously we'll get long-term survivorship. Easy as that. And if a patient recurs or progresses, we can do the same thing over again. We can test new drugs, and we can see if we can improve their outcome. So I don't want to steal everyone's thunder here, but how as a surgeon do I participate in these tremendous outcomes that actually we're starting to see today. Well, I'll start with a few statistics. You got them already. Lots of people have lung cancer, and lots of people die of lung cancer. This is in North America, 154,000 deaths every year. Okay, it's a huge number. And most of these, significant, and definitely most of these patients are presenting with advanced disease, non-operable disease. But a significant proportion are what I'm going to call a window of opportunity. I'll talk to you about that in a second. So no matter when we treat patients, traditionally things haven't been so great. I think today we're starting to be able to make things better. So this is traditionally what dying of cancer looked like. This is what at least I had in my mind growing up of what lung cancer looked like. And I think this is what a lot of the public has in their mind when they think of lung cancer. This isn't true. But one thing I can say is this is not the time to try something new. This means we missed our opportunity. So we have to find new opportunities through existing challenges. And so the patients I'm going to talk to you about right now are these patients I talked to you about with advanced disease, but not very advanced disease. Patients that come and see me in the clinic. Patients that are surgical candidates. So we call this stage 3 disease. This is patients with disease that's both local and has spread to some of the regional lymph nodes, but they don't have spread to distant organs like brain or bone or liver. So these patients are best managed with a number of therapies. So multimodal therapy, we call it, of which surgery is just one part. But the appropriate combination of therapies is associated with better outcomes. The question is, which combination and which therapy? So I'm just going to show you a couple of videos. These are sort of treatment options that are available today for patients with locally advanced lung cancer. This is radiation, and then this is what I do. Okay, this is a surgery. This is a minimally invasive surgery. This patient has a camera put in the chest, and here we're operating on that lung cancer that you saw in the lower lobe. This is sped up a few times. I'm not actually this fast, but anyway, I'll take the credit. Okay, so this is what I do every day, and radiation is also an option. You can deliver high doses of targeted radiation now and get very precise treatment of lung cancers. So I'll let this play out and then we'll keep moving. So, the advent of these minimally invasive techniques has made lung cancer surgery much more tolerable than what it used to be. Patients do very well. Our average length of stay after this operation is about 2 days. So most patients are home in 2 days. There you go, specimen's out, no problem, cured, right? I'll keep moving for the sake of time. Okay, that's not all we do. This is what lung cancer surgery used to look like. Okay, still happens from time to time, much less than it used to, thankfully. Okay, so it's Dr. Spicer right there, and every once in a while, I get a few of these. It means we missed our window of opportunity. So when I say window of opportunity, what do I mean? And so the opportunities that we have to intervene include times, so I kind of like this word, adjuvant therapy. So neoadjuvant, it means before surgery, okay? Primary therapy, so that includes surgery and radiation therapy, surgery right here, and then adjuvant therapy, meaning after surgery. So I want to point out right here that, historically, surgeons have been the center of lung cancer treatment, right? Everyone else is just an adjunct. And that's not true anymore. So I think that in many ways I was fortunate to train and come up at a time where these terms probably aren't true anymore. We're not the primary service, okay? Not everything exists, despite our best efforts. Not everything exists to make our lives better as surgeons. But in fact, we're becoming the adjunct, okay? We're becoming what you get when the medicines that we're able to give now don't work the way we wanted them to, okay? But it's important to know that we have multiple opportunities to see how our treatments work. So in the preoperative period, we can take biopsies, we can give treatments before we operate on patients and see how those treatments work, so it's a natural experiment. The surgery affords us a time to get abundant biologic samples so we can test and understand how our treatments work. And we can use multiple measures of a response to a therapy. Okay, not just I took the cancer out and now we're just going to wait for it to come back. We can measure your response. And in this way, we have numerous surrogates of survival. And what I mean is, I don't have to wait for my patient to die to know that I failed, okay? There are other ways that we can tailor our treatments long before we get to that outcome. So I just want to highlight this study right here. This was published not long ago. Neoadjuvant PD-1 blockade and resectable lung cancer. It's a long title, it's kind of boring. What it means though is we can harness the power of the immune system, okay, which is what PD blockade is, for the treatment of patients with resectable lung cancer. So these are patients that we historically would have just operated on upfront or maybe given chemotherapy to, knowing that our chemotherapy, while it's effective, is not perfect. A lot of patients in the group that I'm describing to you have a high risk of their cancer coming back. So I trained with many of the people on this paper, and I remember when this came out, and there was a lot of excitement about it. And at Memorial in New York, they were one of the first sites to implement PD-1 blockade routinely before we gave surgery, before we performed surgery on patients. So it was exciting to see the results that we got. So I just want to turn your attention here. This is a CT scan, okay? This is a big cancer. It's a much bigger cancer than the ones that we hope to see on screening. Historically, the outcomes for someone with a tumor like this are not great, okay? The chance of cure, probably less than 50%, all right? We would treat these patients with chemotherapy, and if you have a great response, that's wonderful. Again, about less than half do. Now we had an opportunity to treat them with this new immune-enhancing drug, and we repeat the CT scan after they get their treatment, and it looks like, you know, they had some response, but it's not gone. You know, it certainly doesn't look like it wiped the cancer out. Same thing for this person here, but in fact, after resection, so I don't know if you heard what I meant before when I said opportunities to understand how our treatment works, okay? After surgery, we can look at what this image means. In fact, these patients had a complete response, meaning there was no living cancer left in their tumors, okay? That's true for many of these patients. In fact, about 60% of these patients have no living cancer left in their tumors, okay? It's exciting. As a surgeon, it's very exciting. It means, you know, a lot of these people might not need me anymore. I'm becoming the adjunct. This waterfall plot is confusing, but I just want to highlight these gray bars. If we just look at patients, remember how I said before, we look after you survive 5 years, we look back and see what factors predicted your response to therapy. The answer is a lot of them we didn't know, okay? So it just highlights the opportunities for discovery and the opportunities for advancement. All you need to know here is, again, green cells are immune cells. This is before treatment. This is the tumor. This is after treatment. Here's the tumor, and it's covered in the patient's own immune cells, meaning that your own immune system is now attacking your cancer and doing most of the work that we historically used to do. So, this is the window of opportunity, all right? Okay, and here is a locally advanced lung cancer, meaning you have a big tumor and you have lymph nodes with cancer, meaning the cancer spread. This used to be, it still is, I mean, it's not great news, but it used to be much worse news than it is now. So, there you go, window of opportunity. Not frustration in that I can't really make a big impact for these patients, but in fact now we have so many more opportunities to understand the disease process and treat our patients. And as a surgeon, my predominant role now is providing tissue for the other members of the panel that you're going to hear from so that they can optimize patient outcomes. So new ideas, they're going to inform treatment of lung cancer from the earliest stages to the latest stages. And as a surgeon, again, it's really my job as an adjunct to make sure that I can provide biologic samples to inform those decisions. So there are 5-year survivors. They're very happy because of all the work we're doing. And on that note, I'm going to pass things off to my colleagues. Thank you.